Because of that one child, I'm alive today.
Love in the form of a life-saving gift. A cancer patient had to decide which family member would donate his bone marrow. Good morning. It is Friday. I'm Jessica Lovell, and welcome to the Morning Medical Update. Faith gave one cancer patient hope for survival, but it was family that made the healing possible. Today, we are meeting a father and son whose bond is stronger than ever thanks to a life-saving donation. But first, let's get to our morning rounds. The state of Kansas has renewed the University of Kansas Health System's status as a Level 1 trauma center. It is the highest level a hospital can earn. Dr. Stephany Berry joins us this morning to help us understand really what that means to be a Level 1 trauma center. She is an acute care surgeon and the trauma medical director here at the health system. Dr. Berry, good morning. Thanks for stopping in. I know you're off to surgery here in just a moment, so thanks for being with us. The health system was already a Level 1 trauma center. We've talked a bunch about that here on this program, but what happened that let us keep that designation?
So the way that it works in the state of Kansas is the state designates the levels of trauma centers. It's a little bit different in other states. In Kansas, we've decided that the American College of Surgeons verification levels is how we're going to decide which levels of trauma centers that we have within the state. And so every 3 years, the American College of Surgeons comes through and kind of gives us a test, if you will, and looks at our system and looks at what we're doing and making sure that we're maintaining the highest standards and are kind of up to date, creating research, providing education in the community, in addition to the high level of clinical care that we provide.
So explain those differentiating factors. Why are trauma centers divided into those different levels, 1, 2, 3? Why is it important to distinguish between?
Sure. So those designations really kind of help us to understand what are the capabilities at each of those centers. We need trauma patients to come to the right place for the right care at the right time. Time is of the essence when you're dealing with emergencies like that. And not every center can have all of the bells and whistles. It doesn't make sense for it to work that way. And so we want the patients who are the most severely injured to go to the highest level of trauma centers in an expedited fashion.
So maybe give us an example of what a Level 1 trauma center can do that maybe a Level 2 or 3 cannot.
Sure. So Level 1 and 2 centers are reasonably similar from a clinical care perspective. We do still get some patients in transfer from Level 2 centers for more complicated injuries. But the Level 1 centers, a lot of what they do is kind of above and beyond the clinical care. And so we have a lot of requirements for research. We have a lot of requirements for education, both internally within the health system and externally within the community. We have a lot of injury prevention efforts. And so there's just a lot that goes into maintaining that status and making sure that we're kind of staying on the cutting edge. In addition to that, it means we've got someone here. Tomorrow that will be me, 24 hours a day, 7 days a week, 365 days a year, who stands on the ready to take care of an injured patient, no matter what time of day that may be.
So we talk about maintaining that redesignation. When will the next one happen?
So it becomes on a 3-year cycle, and the college comes in and reviews us every 3 years, unless there are deficiencies or problems. But in general, it's every 3 years. We've been a designated Level 1 trauma center since 2000.
Dr. Berry, thank you so much for being with us today and all you do for us in our trauma center. Thank you.
Thank you for having me.
A former police officer who didn't think he even wanted children at the time is ultimately saved by his one and only son. Janine Kiesling explains.
Gregory Russell woke up one morning with a racing heart and decided to get it checked out. Doctors took some blood samples and sent Gregory on his way, but within hours they called, telling him to get to the nearest emergency department immediately.
So I went to the hospital.
After a few more tests, Gregory was admitted.
I didn't understand anything at that point. I was scared.
An oncologist ordered a bone marrow test. That test confirmed Gregory had myelodysplastic syndrome, MDS, a type of blood cancer.
At somewhere along my illustrious police career, I picked up something that was poisonous.
Gregory worked for KCPD for 30 years, 15 of which he worked for the Drug Enforcement Agency, where he went on hundreds of search warrants and handled illegal drugs. He believes exposure to these dangerous drugs likely caused his cancer. For the next year, Gregory was on a low-dose chemo, which worked for a while, but then his condition worsened. He needed a stem cell transplant.
He told me at that point 3 things could happen. I would either get better, I would get an infection, or I can possibly die. And that's why I was so afraid of committing to a stem cell transplant.
Nice deep breaths.
At this point, Gregory's doctor said he needed to go to the University of Kansas Cancer Center.
At that point, I realized I didn't have a choice.
Doctors looked for a stem cell donor on the national and international donor list, and there wasn't a match. But Gregory has an adult son, and he was a match.
Very emotional. When I was told by my wife at that time she was pregnant, I was not in favor because I wanted to get through with my schooling first. But as I look back, it's God sent. Because of that one child, I'm alive today.
Alive and doing well. We're so happy to have Greg joining us here at the desk this morning. Greg, how are you?
I'm blessed.
You are blessed, and you said this is going to be an emotional morning for you, so we're glad you're here to share your story, and we thank you. We're also joined by one of Greg's doctors, Dr. Farat Lutfi, is a hematologist and medical oncologist here at the University of Kansas Cancer Center. Dr. Lutfi, how are you?
Very good, thank you.
Good to see Greg sitting here, huh?
Absolutely.
Always good to reunite. Greg, take us back to the day that you learned something was seriously wrong.
Well, again, it was on a Friday. I took half day off from work. But when I got up that morning, my heart was really beating. There was a little bit of history of high blood pressure in my family and through my mom, and I thought it may have been related. So I went to the hospital, they drew some blood, and I left to go home. I was halfway there, and the phone rang. I didn't answer it. And the phone rang again, and I answered it. And they told me at that point, whatever I was doing, to stop and get to an emergency room as quickly as I could, which I did.
You turned around.
I turned around, and not knowing what was what, and I went to the emergency room, and my red blood count at that time was 4.5. And doctors were amazed that I was not in ICU, because for an adult, it should be 13.5 to 15.5.
Well, I was just going to ask Dr. Lutfi, explain kind of what that 4.5 means. Greg was explaining where it should be, and when you hear that number, what state would you expect to find a patient in?
That's
not driving down the road.
No, I think it's quite remarkable, that someone can still be doing okay, at that point. In general, 4 or 5, the body is unable to get oxygen easily, and the organs are stressed greatly. And actually, much below that, or even at that level, it's generally not thought to be compatible with life. I mean, it's a very dangerous situation.
So tell us about this specific type of cancer, MDS. Exactly what is that?
Yeah, myelodysplastic syndrome is basically a syndrome where the stem cells and other cells in the body are just not producing normally, and you have what's called a clonal disorder, which is basically a cancer.
So why is the hemoglobin rate so low? So which comes first?
So basically you have these cells crowding out the normal cells, and that's what drops the hemoglobin down so much. And so these cells are the problem, and we have to attack these cells, otherwise they completely crowd out the entire normal immune system.
So Greg, your first rounds of chemo were at another hospital. The cancer did not go away, comes back. That's when you were then referred to the cancer center here at KU. What was it like when you first met Dr. Lutfi and the rest of the team? Tell us kind of how you guys tackled this head on.
Well, again, I went in with a little bit of reservations. He came in, introduced himself, and I remember making a quote, a biblical quote, that you're only promised 70. And his response to me was, his job was to make sure that I go beyond that 70. And I want to say love at first sight, but at that point, I put my faith in him.
Well, yeah, love at first sight and faith, the faith connection that what was it like when you met Greg? I mean, this is a man of faith. He's ready to go to work and fix this.
Just a remarkable man, a very strong man, and a person, I want to save all my patients, but meeting this person, we had, I think, an instant connection, which I think is very important, and just so impressed by this person, and I felt that I have to do everything I can to give this person his life back.
But Greg couldn't do it alone. He needed a bone marrow transplant, we learned. The donor registry did not have a match. We know it's worldwide. Not always easy to find a match. So doctors start asking around. The first thing they do is start to ask family members. And your son, Greg the second, here in this photo, but let's actually bring him in live because he's joining us from Florida this morning. Greg, good morning to you. How are you?
I'm blessed. Very well. Good morning.
Two blessed men sitting here together. We love to hear that. You learned your dad was dealing with cancer. What was it like when you found out that he needs your bone marrow to save his life?
Obviously, when you hear anyone in your family is dealing with cancer, there's a scary feeling there, right? Because it's it could be such a deadly disease. So scared, anxious, just unknown, like mysterious. But when I was asked or told that I would possibly need to be a donor, it was sure, no problem. Where do I sign?
Mysterious. That's a really good way of putting it. You hear you're going to be a possible match, and you're kind of going on to this journey that you've never even heard or expected in your life. Greg, we're going to show some photos of you, your grandsons through the years when doctors were looking at possible donors. It could have actually been your son or your grandson, Gavin. He's 16 years old now, a nice young man, but you told us that you didn't want Gavin to be the donor. Tell us why.
Well, I knew little about the process, but I was told that it was very painful. And at that age, he was 15, and I wanted to spare him that pain. And that's why I insisted that the donor would be his dad, my son.
How often is it, doctor, that you find two people in the family that either one could be the donor? And then how do you make the decision who's going to go?
Very good question. So, we can do half matches now. This is something that we've been doing in more recent years, which has really benefited patients who don't have anyone in the registry. And so, by definition, a half match, a son or a daughter, will be a half match. It gets a little bit more tricky when you're talking about grandchildren. Then it's kind of, about a 25% chance or so. But fortunately, any children are effectively a half match.
So Greg, you traveled here for the donation. You talked about this being a mystery. So help us kind of demystify what it was like. Tell us about the process for someone who may go through this in the future.
Yeah, sure. So, I think that's the best way to put it, because you don't know what you don't know, right? So I just had to, listen to the advice of the doctors and what everyone was telling me, and just take it one day at a time, one step at a time, and just have faith and believe that everything was going to work out the way it needed to work out.
Tell us how it felt like and how long it took.
The process.
Yes.
So
take us inside.
Yeah. So, they had told me that a possible side effect of the process would be I would feel sore. And I could look back on that now and say that is an understatement. So what happens is I had to go through 4 days of injections where they gave me a drug to induce my stem cell count, right? Because obviously I'm going to be donating stem cells or giving that away to my dad. So they wanted to induce that population. Well, a side effect of that drug was it would make me feel sore. So For those of you that work out, if you work out at the gym routinely, and then you stop, let's say you take a month off or a few months off and you go back and you start working out again, that next day or the second day, you feel sore from working out that body part. Well, that's what I equate it to, except it's your whole body and it's time 100. So very uncomfortable, but it was tolerable. I'd do it again a million times over.
Doc, is that side effect pretty typical, and are there other side effects?
So yes, we have to give a growth factor basically to get the stem cells kind of out into the peripheral blood so that we can filter them out. And so unfortunately that causes basically in the deep part of the bone, the marrow, it causes quite a bit of discomfort and pain. I would say probably over 80% of patients experience that, but we have some medications to kind of help out. I don't know if those necessarily helped out, but we generally, I think the description that you have is very on point.
So Greg, I have to know, we want to know a little bit more about your relationship growing up and into manhood and fatherhood. Was there any doubt that your son, Greg, would do this for you?
No doubt at all. It was quoted this morning, I gave him life.
You can take your time. I know you said this would be emotional for you.
I gave him life, and he gave me life back.
Greg, what's it like to hear your dad, see him be emotional, this big guy, ex-cop, and you're able to step in and forge that bond?
It's tough, right? Because growing up, my dad, first of all, he's a police officer, so there's already that level of authority there just from the nature of his job. And then he's my dad. So as a kid, he was a very, there was some fear there, right? He's a police officer, he's my dad, and he's very, stern when he needs to be. So, but at the same time, he's a great father. He was a great father. He is a great father. He'll continue to be a great father. And we had this father-son relationship all the way up until I was 18. And when I turned 18, it's like it changed overnight for the better. He just told me, he said, look, I've done all I can up until this point. You're a young man now. So from here on out, it's, you need to start being accountable and learn on your own. I'll always be here for you. Whenever you need me, I'm here for you. But now it's time for you to basically leave the nest, step out and, learn what it takes to become a man in this world. And ever since then, we maintained our father-son relationship, but we also became very close friends, best friends. When I need a friend to talk to, he's there. I can call my dad. When I need, he's like a brother, like the brother I never had. So we're very close. We have a very strong bond, and it's to see him in this state, like it's rare that I've seen him vulnerable and break down. So to see that, it instantly just breaks me down, and I'm trying to hold back the tears right now myself. But I love him to death, and he's been a wonderful joy in my life, and the grandkids, my sons, we love him.
Thank you for sharing that. Greg, what's it like to hear him talk about you like that? Because your job was done. You did that tough love, and you set him out into the world, and then it came back full circle.
I did, and through our relationship, I watched him exhibiting or displaying his fatherhood. And I told him, and I will continue to tell him, that he's a much better father than I was, because when he talked about being stern, that's how my father raised me. My father would always tell me, hey, live by the sword, die by the sword. Whatever you do, it'll come back, and make sure it's the right thing. So with him, I had no issues with the child growing up, but I watched him. Our methods are vastly different. He is more patient, and he speaks in a gentle way to both of my grandsons. If it was me talking to him, it would be a stern voice, and that's the difference, I think, in the generation. And I keep telling him there was no book for me to follow as a father. So I copied what my dad did to me and did to him. And that was my go-by.
Well, both your styles are very effective. You know, it's. I think, you know, we remember growing up with our dads, and it's June, so we're talking a lot about fathers and shining the light on those relationships. So this story is really wonderful. I have to say though, Greg, you talk about your faith, and when I met you in your hospital room, you had said that you're going to stay off the golf course a little bit more, and you're going to stay in church a little bit more. Tell me about that.
Well, I remarried, and I grew up in the church. My background growing up in the Bahamas was all about church on Sundays. And, you know, when I came to Kansas City, I bounced around from church, and again, raised by my grandmother per se. And Sundays, the day of Sabbath, was the day you went to church, and you did nothing else on Sunday. So I knew for me, you know, the book says, train a child in the way he should grow, and when he is old, he will not depart from it. I had that background, and I knew on Sundays I was not continuing how I was raised. So it was very important for me to find a church home, and we did. So instead of going to golf courses now on Sunday, I will first give my praise to God, and then whatever else happens that day will be the rest of it.
You can golf every now and then, though, Ben, right?
Oh,
Every now and then. You got to stay up on your skills. So.
Yeah.
All right, so be sure to ask your questions to any of our guests today. Use the chat on YouTube, Facebook, tweet us, or email the Medical News Network. The info is right there on your screen. Let's get a quick checkup or COVID count. Dr. Dana Hawkinson, Medical Director of Infection Prevention and Control. Happy Friday. Yeah. How are you?
Hi, I'm good.
Good.
It's nice out, too.
Yeah.
Even better, though, is here at the health system. We still have those single digits for active infections. We have 17 total, 7 active. Unfortunately, we do have some severe illness, 1 in the ICU and on the ventilators.
Okay, we want your thoughts on a quick headline, if we may. China is dealing with a new wave of COVID cases fueled by the XBB variant. One scientist model suggests the weekly number of infections could peak at 65 million by the end of June. Now, previously, the Chinese government was very strict about lockdowns and masks, as we know, but this time around, not so strict. Just what are your thoughts on this?
Yeah, I mean, well, again, this is stark contrast of what is COVID doing in any distinct community. Certainly we know in the United States it's low, but then we look at China. They had that zero COVID policy for so long. Now there is no restrictions. Now it's more of a zero restrictions policy. It's very hard and difficult to get information out of China for various reasons. One, just because of the lack of total transparency, but also we know that people in China are kind of similar to the population in the United States. Not so many people are going for PCR tests, getting tested. But what we do understand is that so far their clinics, their hospitals are not overwhelmed. So that is a good thing. That could have to do with some previous infection, but also some of their vaccines as well and vaccinations. So yes, some of the reports say that they have peaked already, and some are still expecting maybe a peak a little bit later in June. But right now, I think the best evidence would support the fact that they aren't being overwhelmed in their healthcare facilities as they were. But again, some of that news is spotty. And I think the main concern is that if you have so much circulation in a community, will that help give rise to other new variants? And that is certainly always a concern. We know there is a global surveillance network looking for those new variants, but right now it just seems to be the XBB 1.5 and 1.16, I believe, the 2 very common variants that we've been having here in the United States as well. And again, all of these variants so far are sub-lineages of that original Omicron variant as well.
Any reporters with us today? Let's get to our community questions. And first one up, Doctor, do we know what causes MDS?
You know, it's a multifactorial thing. It typically has what we call multiple hits. So some can be genetic, some can be environmental, things like benzene, classically, or even radiation exposure. And then some of it is just kind of random roll of the dice, so to speak.
Yan Yang wants to know, would MDS be seen as a cancer or an early stage of leukemia?
Kind of both, actually.
Okay.
So historically, we would consider MDS to almost be a pre-cancer, but in reality, it's the same thing. It's a spectrum disorder. And so when leukemia, the blast count, the percentage of those cancer cells, when it gets over 20%, we call it leukemia. When it's under 20%, we call it MDS. But they're effectively the same disorder.
Yulin wants to know, what's the difference between a bone marrow transplant and a stem cell transplant?
We use the words rather interchangeably,
Okay.
but the source is the difference. Bone marrow versus peripheral blood. We use both. Like in the case of Mr. Russell, we used peripheral blood.
Jennifer wants to know, were there other treatment options for Greg had he not been able to find that donor match?
Well, there would be other treatment options, certainly, but in the case, the type of MDS he had was high risk. And so we consider the only curative treatment to be a bone marrow or stem cell transplant.
And question from Benny, are Greg's sons, and Greg II's sons, are they more at risk now of this type of cancer?
So I don't think so. There are some familial disorders that can occur that are usually certain types of mutations. But no, I would not think so. And actually, that's a very good question that comes into mind when we're choosing a donor. But no, I do not think that he would be at higher risk than the general.
And speaking of donors, why is it so hard to find a donor worldwide? You have this big, you're casting this wide net, but you're looking for this very specific match.
Yes. Well, so it's challenging because we have to have what's called the HLA matching. So all of our immune systems have a certain profile. And so we need to have a match, and that's typically related to genetics and also to geographic location. And so, for instance, for the North American Caucasian population, about 70% of patients will have a match. But in other populations, we just have less people on the registry. And again, that's why it's so important that we're able to do half matches now so we can open people up to transplant who otherwise would not have a potential donor.
And also equally important to reach out to be the match, do that swab. It's
Absolutely.
so easy, right? It's so easy,
Absolutely.
send it in and one and done.
You can save a life literally by just taking a 2-second swab. I mean, it's a really remarkable thing.
Let's get our takeaways today. And Dr. Lutfi, thank you for being with us today. What do you want folks to take away from this conversation?
So I think certainly general population being able to be a donor is wonderful. The other thing I would say is that hematologic malignancies, while a scary thing, is something that we've really made so much progress on, and our outcomes have improved, and we consider these really to be curative disorders at this point, and things are only improving as we go forward, and a lot of that is based on the initiative certainly at KU, the clinical trials that we have, and of course having the support of our patients.
Greg, thank you so much for joining us from afar today. We appreciate you being with us. What's the takeaway from your story and the story with you and your father?
First and foremost, God is good. And, second, for anyone else that's watching this or sees this and they're in my position, just be strong, be faith, and have the faith. And it's a great feeling after it's all said and done. You go through the side effects and whatnot, and there are those challenges, but after it's all said and done and it's successful, you don't even think about it. It's worth it, and I'm just happy to see my dad in a better state, and on the road to a successful full recovery.
Greg, I'm going to let you have the final thought today. What's the takeaway from this story?
Well, we pray for miracles when we're sick, and we think that through a night's sleep or whatever, we're going to be touched and we're going to be cured. What we don't think of is God works in a mysterious way, and by putting Dr. McGurth and Dr. Lutfi in my life, they were my miracles for cure, and that's important. It's not going to go away, but because of these two fine doctors, I'm on my way to being able to extend my life.
Thank you so much for being here and sharing your story. We appreciate it. Thanks to all of our guests and viewers for being with us today. We'll see you back here Monday. Have a great weekend.
Coming up Monday on the Morning Medical Update, Darren McLaughlin's doctors knew he had cancer, but they didn't diagnose it correctly. Switching to the University of Kansas Cancer Center made a crucial difference. I'm Alexis Del Cid on the next Morning Medical Update, how Darren got the correct diagnosis and access to a life-saving treatment most hospitals don't have. Monday at 8 a.m.
Subscribe to our Morning Medical Update and Open Mics with Dr. Stites podcast. Now, everywhere podcasts are available.